Welcome back, everyone. Today we're going to begin our discussion on respiratory physiology. Today we're going to talk a little bit about an overview of what respiratory physiology is and the main overarching themes. We're going to talk a little bit about the anatomy of the respiratory tract, a little bit about the mechanics of breathing, and we'll end today by talking about total pulmonary ventilation and total alveolar ventilation. When we talk about the respiratory system, there's really four major functions. Number one, there needs to be exchange of gases between the atmosphere and the blood. If we can't exchange those gases, we can't get oxygen to our cells that need it from the external environment. And we also wouldn't be able to exchange carbon dioxide from our blood back into the external environment. The second major function of the respiratory system is really regulation of pH. This is something that people often don't think about when they think about our respiratory system, but it is a fundamental function. And it does this by releasing CO2 or retaining CO2. And we're going to talk about this briefly. We're going to get into this in a lot more depth in our renal section. The respiratory system also helps protect us from inhaled pathogens, so viruses, fungi, bacteria. There are specific mechanisms within our respiratory tract that help protect us from those pathogens getting into the smaller airways. And our final function of the respiratory system is for vocalization, for communication. There are two terms that you should know the difference between: cellular respiration compared to external respiration. When you hear the term cellular respiration is specifically the intracellular process of using oxygen with organic molecules to produce carbon dioxide and usable energy. Usually that's in the form of ATP. And so we talked about the major process of cellular respiration of the catabolism of glucose in an aerobic fashion. The external respiration, on the other hand, is specifically the movement of gases between the cells and the environment. And there's multiple processes that you have to keep in mind when you talk about external respiration. And there's four in total. There are three exchanges that happen in external respiration, and there's one transport process that happens. So the first thing that's involved in external respiration is the movement of gases from the atmosphere into the lungs, or from the lungs into the atmosphere, both directions. So if we're talking about air coming into the lungs and into the small airways, that's going from the external environment into our small airways. So we're having oxygen in there, and that's the first exchange, atmosphere to lung. And that's sometimes referred to as ventilation. So our exchange one is ventilation. The next exchange is a diffusion exchange that's happening between the lungs and the blood. So this is between the small airways within the lungs, the alveoli, and the capillaries that surround the alveoli. And so in this exchange, you're going to have oxygen moving into the blood, and you're going to have carbon dioxide moving out of the blood. The next phase of external respiration is the transport phase, whereby oxygenated blood is going to be moving throughout our circulatory system to reach the peripheral tissues. And when it reaches those peripheral tissues, there's an exchange that happens at that point. That's the third exchange, whereby oxygen is going to leave the blood and enter the individual cells, and carbon dioxide is going to leave those cells and enter the blood. It's within those cells that cellular respiration is happening. So cellular respiration is specifically once the oxygen reaches those cells, the oxygen will be utilized by the cell. That's cellular respiration. And then that transport phase also includes movement of the blood back to the right side of the heart and back to the lungs so that the waste product of carbon dioxide can be diffused across. So at every single exchange, there's a movement going in and a movement coming out. So at exchange one, there's movement of oxygen going in, but there's also movement of carbon dioxide going out. At exchange two, same thing. Oxygen is coming into the blood and carbon dioxide is leaving the blood. Exchange three, oxygen is leaving the blood and going into the tissues, and carbon dioxide is leaving the tissues and going back into the blood. The anatomy of the respiratory tract can really be divided into two major parts. There's the upper respiratory tract, which includes the mouth, the nasal cavity, the pharynx, and the larynx. Pharynx, back of the throat, and the larynx is the voice box. The upper respiratory tract, you'll notice that there is some overlap between the GI tract. Mouth is included in both. The lower respiratory tract includes the trachea, the bronchioles, and all the branches. So the trachea, anything inferior or distal really to the, it's not really distal, I guess it's inferior to the larynx, the windpipe, anything from there and lower down is considered the lower respiratory tract. The major anatomy of the respiratory tract includes airways, alveoli, and everyone usually forgets about the bones and the muscles of the thorax that are also important in the function of the respiratory tract. And not only are the bones and muscles of the thorax important in normal functioning of the respiratory system, also the muscles of the abdomen can sometimes assist in ventilation as well. So we're going to talk about each of these. We'll start off with the bones and the muscles. They make up the thoracic cage. And so the bones of the thoracic cage include the ribs, the sternum, and the vertebrae. And so you have 12 pairs of ribs, so for a total of 24. You have one sternum, which is divided into three parts. There's the manubrium, the body, and the xiphoid process. You don't need to know the parts of the sternum. And there are the vertebrae. There's specifically the thoracic vertebrae. Each pair of ribs attaches to one of those thoracic vertebrae. So there's 12 thoracic vertebrae. I remember I was part of this trivia group a few years back, and one of the questions was, it was sort of a multiple choice question. It said, which part of the body contains more bones? Is it A, the skull, B, the hand and wrist, like one hand and wrist, C, the foot and ankle together, or D, the thoracic cage? And so I went through and I calculated all the bones of the hand and wrist, and then all the bones of the ankle and foot, and all the bones of the thoracic cage, and I thought, well, it's definitely the hand and wrist. Anyways, when I was calculating the bones of the thoracic cage, I completely forgot to calculate the 12 thoracic vertebrae, because there's more bones in the thoracic cage than there are in the hand and wrist together. And so anyways, nobody ended up getting that question right in trivia, and I got a bit of a call out for that. The quiz master said, so nobody got the anatomy question right, including our doctor, who's part of one of the teams. So anyways, I'll never forget to include the thoracic vertebrae as part of the thoracic cage, and you shouldn't either, actually. So please remember that, so that you don't run into a situation like me. Anyways, I digress. The muscular component of the thoracic cage includes a few types of muscles. There are the muscles that are within the thoracic cage itself, and those are the intercostal muscles. Whenever you hear the root word costal, always think ribs. And so the intercostals, like international, between countries, these muscles are between ribs, between the costal margins of the ribs. And so there are multiple layers of intercostals. And they assist in breathing and getting air into the lungs, and somewhat maybe getting air out of the lungs, although that's more of a passive process under normal circumstances. There are also muscles that are sort of external to the thoracic cage, but have an attachment to the thoracic cage, and they're more muscles within the neck. And those muscles include the sternocleidomastoid. And just like its name implies, there is it has an attachment to the sternum, to the clavicle, clido, and the mastoid process is a bony prominence within the skull. And so it's the sternocleidomastoid. And then there are other muscles called the scalene muscles, which are muscles of the neck, and they attach onto the thoracic cage, and they assist in breathing. Inside of the thoracic cage, there are two lungs, and under most circumstances, there are two lungs, and the lungs are mostly spongy tissue. They are mostly air, and most of it is empty space. And the airways actually connect to the lungs, so the actual tube components connect to the lungs, and we're going to talk a little bit more about the tube component in a little bit. Surrounding the lungs, I'm showing you a different section of the thoracic region of the body. This is an axial section, so you can see a cross section of the lungs, and you'll see that there's actually a covering around the lungs. There is a covering that surrounds it, and it's actually a double layer membrane that covers the lungs. So it actually is along the surface of the lungs, and then it reflects back on itself and starts to line the actual rib cage with muscles. So it's almost like there's a deflated balloon covering the lungs. So at any point in time, if you were to take a small section of this, it would look like there's two layers of this covering, but it's one continuous layer. There are two layers, but it's just one continuous layer. It's like a deflated balloon. There would be two layers of the rubber from a balloon that would be covering the lungs if you thought of it like that. There's one side that's attached to the lung itself, and there's one side that's attached to the muscle and ribs itself. This particular covering is called the pleura, and this pleura forms sort of like a sac around each lung. And within that pleura, there's a space between there. And there's a tiny little bit of fluid within there. And that little tiny bit of fluid allows for a very moist, slippery surface when breathing. So it allows for you to inflate your lungs and deflate the lungs in a relatively frictionless environment. But it also ensures that as you inflate your lungs, the two layers actually will stick together because it consists of pleural fluid within there, and the pleural fluid helps make sure that those two layers stick. So I kind of want you to think about the pleura as two thin layers of glass with a little bit of water between them. Those two thin layers of glass would slide very easily over each other, but it would be quite difficult to pull those two thin layers of glass apart if there's a little bit of water between them. So they will still stick together. One thing that I do want to mention to you is that the two layers of pleura, you should actually know the names of the pleura. I'm actually going to exit presentation mode right now, and I'm actually going to add a text box here that the layer that is attached to the lung itself is called the visceral pleura. And that is attached to the lung. And the layer that's attached to the rib cage and to the muscles and the bone itself is called the parietal pleura. And you'll actually see this on your slides because these are the slides that I'm going to be uploading to the site. So you'll already have this on your slide, is attached to rib cage. So you should know that anytime that there's a covering around an organ, there's usually a double layer around the organ. There's the layer that's attached to the organ itself, and that's always called the visceral layer. So this is no different. The visceral layer is attached to the lung, and there's always a parietal layer. And this is the layer that's attached to the musculoskeletal, or more, is not attached to the organ itself. And so that's the parietal layer. So if you recall the pericardium, there was a visceral pericardium that was attached to the heart itself, and there was the parietal pericardium that was just superficial to that was attached to the fibrous pericardium, and so the parietal pericardium was not attached to the organ itself, and that's exactly the same thing as the pleura. If you are in anatomy and you're learning about the GI tract or the abdominal region, you'll probably have learned about the peritoneum. There's a visceral peritoneum and there's a parietal peritoneum, and it's the exact same nomenclature. The visceral peritoneum is attached to the organ itself, and the parietal peritoneum is attached to the walls around it. Okay, so don't forget about the pleura. It's going to come back when we talk about the mechanics of breathing. So our airways connect the lungs to the external environment. And so the process by which air enters the lungs, air comes in from the external environment, either comes in through the mouth or the nose, can come in through either, and then it enters the pharynx, which is the throat. It goes past the larynx, the voice box, and then it enters the trachea, or the windpipe. And there are several functions of the upper airway as air passes through, as things pass through. Number one, the upper airways function as that passageway for air. Number two, the upper airways act as a means of warming the air before they reach the lungs. If you ever tried to take a deep breath on a really cold winter day, you'll know that it kind of hurts. And it's because some of that air is cold. It needs to be warmed before it gets into your lungs. And sometimes it'll hurt so much that you'll start coughing and you'll start expelling the air. The upper airways also add a bit of water vapor so that the gas exchange surface within the lower airways doesn't dry out. That would not be a good thing for diffusion, and it would make that moisture make sure that the surfaces stay intact. The other function of the upper airway is to filter out foreign material, dust, viruses, bacteria, anything that can get into your lungs that shouldn't be there. It helps filter it out. When we talk about the bronchial tree, it's a series of tubes that carry air, and it starts with the trachea. And the trachea is a rigid tube with C-shaped cartilage. And so if you were to look at the trachea, you'd actually notice that the rings, there's these rings of cartilage that don't surround the entire circumference of the trachea. At the end of the trachea, there is something called the carina. This is the carina, where the trachea splits into what they refer to as a pair of primary bronchi. And one of those primary bronchi go to the right lung, one goes to the left lung. So I just want to make a little point about the trachea itself. I'm going to make sure that I don't have a slide on that. So I don't. So that's good. So I'm going to just share my screen with you and make a couple of notes about the trachea. And what it sort of looks like from an anterior view or a front view, and a posterior view or back view. So when we look at the trachea, it's these, if you look at an anterior view, you'd see trachea, and there would be these cartilaginous rings that are along the length of the trachea. And if you were just looking at the anterior view of the trachea, it would appear as though those rings go all the way around, but they don't. If you were to look at the posterior view, you'd actually see that there is these rings of cartilage stop. And what's in between that ring of those incomplete rings of cartilage is a layer of smooth muscle. So there's this layer of smooth muscle that's not striated, so I'm trying to make it not striated because it's smooth muscle. And so the posterior part of the trachea is is not rigid like the rest of the trachea. And so one of the things that this brings about is, well, what structures are in the area of the trachea? So there is, if you think about what's just behind the trachea, the esophagus is just behind the trachea. And so it is actually possible to have something get stuck in your esophagus, push on this smooth muscle to the point that it blocks off your entire airway. And so it's possible to choke on something that is not even in your trachea, because if it's stuck in your esophagus, it can push on your trachea and block off the airway to the trachea so that you can't get air in. These C-shaped cartilaginous incomplete rings, because they're separated by that smooth muscle, that smooth muscle can be pushed inward by things that are compressing the trachea from behind. And so I just wanted to point that out. So we're going to go back to the presentation mode. We're going to go to, where are we going? Here we are. Okay. So the bronchial tree, what I want you to notice about the bronchial tree is that you get those primary bronchi. Each one of those is called a primary bronchus, and it goes to one lung each. Eventually, what you're going to notice is that these bronchi have sort of these ring-shaped cartilages that are along it, but as these airways get split into from primary bronchi into secondary bronchi, and as those airways split, I want you to notice that the cartilage gets less and less a constituent part of those airways. As they get smaller and smaller, the cartilage is more and more replaced with smooth muscle. And eventually there comes a point after it branches into the smaller airways that you have no cartilage at all. And so this really brings up the important definition of the difference between a bronchus and a bronchiole. If you have a bronchus, or plural bronchi, if you were to look at a histologic section of that airway, there would be cartilage in it, some degree of cartilage. Bronchioles have absolutely no cartilage. And that's how you can tell the difference between a bronchus or bronchi and a bronchiole or bronchioles. And so as you get smaller and smaller and smaller airways, each division, you get smaller and smaller tubes, but you get more and more tubes for the air to go down. And so there are around 23 or 24 divisions that occur within the bronchial tree. And so you can actually see how quickly that number adds up. You go from the trachea to the primary bronchus, or primary bronchi, there's 2 of them, to a split that's now 4. There's really 5, but we're just going to not include the extra one there. But they're all exponents of 2. And so each division, you're multiplying the number of airways by 2 and multiplying the airways by 2. And by the time you get to the smallest airways, you're already at 80 million airways. And that serves to massively increase the surface area, to maximize the amount of gas exchange that can happen across the airways. And so at the very end of the branching, the final destination of air is something called the lung lobule. And the lung lobule contains alveoli, which are those sacs. And you can actually see some of these sacs. These are all like, it's like a bunch of grapes. And each of those sacs will have air. And each of those sacs is actually going to be a single layer of cells thick and will be covered by capillaries. So that there is a single layer of cells with a capillary over top of it, and it allows for gas exchange to happen because it's over a very short distance. If we take a closer look at the internal structure of an alveolus, you'll see that it's mostly comprised of these flat cells. And anytime that you see a flat cell, it's referred to as a squamous cell. So these are squamous cells. And the specific type of cell it is something called a type 1 alveolar cell. And you'll see that the majority of the circumference of an alveolus are these flat cells. Most of the area is covered by them. Very thin, and it mostly facilitates the diffusion of gases. That's a type 1 alveolar cell. Type 2 alveolar cell they're thicker cells, and they're not that frequent. They make up about 5% of the cells within the alveoli, and the function of these cells is to, number one, remove excess fluid, but also to produce a substance called surfactant. And surfactant we'll talk about a little bit later, that is very important in making sure that we can inflate our alveoli similarly, and it doesn't matter how large they are. But we'll get back to that. The type 1 and type 2 alveolar cells are sometimes referred to as, oh dear, I stopped sharing. Okay, just a second. I need to continue to share here. Here we go. Okay, that should do it. I just want to make one note here that'll be on your slides. A synonymous term with a type 1 or with a type 1 alveolar cell, it'll sometimes be referred to as a type 1 pneumocyte. And pneumo means air, and it means an air cell, which is part of the lung cell. It's exact same thing for a type 2 alveolar cell. Can be referred to as a type 2 pneumocyte. And so that should be on your slide already. So those terms can be used interchangeably. I could use them interchangeably if we're on a test. Just make sure that you know both terms. But that alveolar cell and pneumocyte mean the same thing. Okay. So the capillary network around the alveoli is extensive. And so the alveoli are covered with a network of capillaries, and it's almost like they're covered with a sheet of blood. And that ensures that the entire alveolus it will be a good surface for gas exchange. And so if you look at the membrane linings, you'll actually see that here's the alveolus, here's the air within the alveoli, here's the cell within the alveoli, and then here is the lining of the capillary. Very, very small and small distance that diffusion has to, over which diffusion has to take place. So it's around 0.1 to 1.5 micrometers. And so that just really shows that the diffusion will occur very efficiently. And it's set up that way so that diffusion can occur efficiently and gas exchange can occur very quickly. Going with the blood flow around the alveoli, the pulmonary circulation is actually quite an interesting circulation. It's a very high flow circulation, but it's a very low pressure circulation. And so remember, the cardiac output from our cardiovascular section is about 5 liters per minute. And so whatever is going out of the left side of the heart has to be coming through the lungs as well. So the cardiac output on the left side of the heart is exactly the same as the cardiac output from the right side of the heart. So if 5 liters per minute are leaving the left side of the heart, that means that 5 liters per minute is also going through the lungs. So you're having 5 liters of blood per minute being oxygenated, returning to the left side of the heart, and then being pumped out. So that shows the high flow, but it's a very low pressure circuit. And the low pressure is the result of, number one, the shorter length of the blood vessels within the pulmonary circuit, and the massive total cross-sectional area of the blood vessels. The number of capillaries is astronomical within the pulmonary circuit. So it's a very low pressure circuit, but very, very high flow. So just keep that in mind, that right-sided cardiac output is exactly the same as left-sided cardiac output. It has to be. If you had more going into one side than the other, you'd have a backup of blood somewhere, and backup of blood is not good. One thing that you really need to understand throughout this section are some of the gas laws. And this will bring you back to chemistry. So some of the gas laws that we're going to talk about are Boyle's law and Dalton's law. But we have to think about air, first of all, as being similar to blood. Both are fluids, so they follow the fluid laws, but the difference is that air is compressible because air is a gas. So there are several extra laws that govern the properties of gases. And so number one is the ideal gas law and Boyle's law. Both of them are important, but both of them are really helping you say the same thing. And so the ideal gas law, if you remember, PV equals nRT, that is the ideal gas law. The Boyle's law is P1V1 equals P2V2. So the pressure times the volume of a certain gas, if you change the pressure of that gas, the product of the pressure and the volume of that gas stays constant. That's all it's saying. And so if we look at the equations from a physics perspective, we'll see that what both of these laws tell us is that pressure and volume have an inverse relationship. So if you solve for volume 1 in Boyle's law, or you solve for pressure 1, volume 1 goes on the denominator. So the pressure and the volume are on different parts of the fraction, so it's an inverse relationship. As pressure goes up, volume goes down. Same thing happens with PV equals nRT. If you solve for volume, pressure and volume are an inverse relationship. And so if you were to take some sort of a gas at a certain pressure, 100 millimeters of mercury, and it occupies 1 liter, if you were to increase the pressure of that gas to 200 millimeters of mercury, it would only occupy half a liter. So higher the pressure, the lower the volume. But notice that if you take the product of both of these values, 1 times 100 is 100, 0.5 times 200 is 100. The product of the volume times the pressure is equal. And that is told to us by Boyle's law, that we should get the exact same value. But the big thing to know is that there is an inverse relationship between volume and pressure when we talk about gases. Dalton's law talks to us about air being a mixture of gases, and that the total pressure exerted by a mixture of gases is equal to the sum of the pressures exerted by each individual gas. And so we can determine how much each gas contributes to the overall pressure by calculating something called a partial pressure. And here's an example of that. So if we know that air in the atmosphere is a certain pressure, and we know that a certain percentage of that air is made up by a particular gas, if we take if we multiply the percentage of that particular gas by the total pressure of the air, of the mixture, we'll get how much pressure is contributing to the overall pressure. Totally confusing. Let's do an example. Oxygen makes up about 21% of the air we breathe. If the normal atmospheric pressure is 760 millimeters of mercury, oxygen will make up 21% of this number. That's all that Dalton's law is saying. So 760 times 21% means that oxygen, if you work this out, will be contributing 160 millimeters of mercury to the overall pressure. If you were to take nitrogen, it's about 78%. You would just, and you can determine how much pressure nitrogen is contributing to the overall atmospheric pressure by doing the exact same calculation. And instead of multiplying by 21%, you'd multiply by 78%. And after you determine the pressure of each gas, if you add them up, you should get the atmospheric pressure. Dalton's law is just saying that all of the overall pressure of a mixture of gases is just the sum of the individual pressures of each gas within the mixture. So those are the gas laws that are really important in this section of the course. Because air is a fluid as well, it acts as a fluid, it tends to follow some of the laws of fluids as well. And fluids tend to go from an area of high pressure to an area of low pressure. And so airflow occurs when there's a pressure gradient, when there's a difference in pressure between two areas. And so air tends to flow from an area of high pressure to low pressure. And so we can actually take this concept and talk about it in terms of diffusion of gases and what direction the gas is actually going to flow. So the diffusion of a single gas will move from an area of high partial pressure to an area of low partial pressure. And so when we're talking about the diffusion of a single gas, we're talking about the partial pressure of that single gas across two areas. And when we talk about the movement of oxygen across the alveolar membrane into the capillary, we're going to see how the partial pressures are important in determining the direction of diffusion. Ventilation, when you hear the term ventilation, all that means is the bulk flow of air from the atmosphere into the alveoli. And there are various volumes that you can talk about when we discuss ventilation, and it's part of something called the respiratory cycle. And the respiratory cycle is simply an inspiration followed by an expiration. But we know that all inspirations are not made equally, and all expirations are not made equally. We can inspire more air. We can inspire less air. We can expire a certain volume of air, but we can also force ourselves to expire more. So there are specific names that we give to the volumes of air that can exist in our lungs during ventilation. When we're talking about normal, quiet breathing, that's just occurring. We're not really thinking about it. We're bringing in a certain amount of air and we're exhaling a certain amount of air. That volume of air that we're bringing in is referred to as a tidal volume. It's the air that moves with normal inspiration and expiration. It's about 500 milliliters in a normal person. There is room, though, if we want to breathe more in and take a deeper breath, we have more air that we can actually breathe in. And that extra air, if we want to breathe more air in, that is a volume of air that's referred to as the inspiratory reserve volume. So anything above that tidal volume is referred to as the inspiratory reserve volume. That's the additional air that could be breathed in if we want to. When we talk about exhaling air, normally during quiet exhalation, we're just exhaling that tidal volume, but we could forcibly exhale more air than that tidal volume. And that particular volume of air that we could exhale is something referred to as expiratory reserve volume. So that's the extra amount of air that we can exhale after the tidal volume. No matter how hard we try, our muscles in our body are not strong enough to exhale all of the air within our lungs. And there's always a little bit that's left over. And that particular volume of air, it equates to about 1,200 mils. So about 1.2 liters of air is always going to stay in our lungs, no matter how hard we try. And that particular volume of air is referred to as residual volume. And so notice that everything that I talked about, I referred to as a volume. We can also talk about things called lung capacities. And whenever we talk about a capacity, it's always talking about the sum of two or more of the volumes that we just talked about. So if we were to take the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume plus the residual volume, absolutely everything, the sum of all of those volumes is called the total lung capacity, which makes sense. It's how much air can possibly fit in your lungs. If we just talk about how much air, what is the total volume of air that we can possibly inspire? This is referred to as the inspiratory capacity. And so because it's a capacity, it consists of two or more volumes. So we know that it consists of the tidal volume and the inspiratory reserve volume. That's the inspiratory capacity. Another capacity that is important is something called the vital capacity. The vital capacity is exactly the same as our total lung capacity, except we don't include the residual volume. The vital capacity is everything that we can possibly inspire plus everything that we can possibly expire. That is vital capacity. There's one more capacity that's not on this slide, but it's actually in the picture here. If we talk about the expiratory reserve volume plus the residual volume, that's something referred to as the functional residual capacity. That's the only other capacity that is of importance. But the big one, vital capacity, inspiratory capacity, and functional reserve capacity, total lung capacity. Those are the four that we typically talk about in respiratory phys.